Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. So, welcome back to the program. This is Aebhric. This week, I am talking with Zack Andrews. Zack, you're a SOF medic. You're an active duty medic. You're stationed in Hawaii, and your job is Human Remains Retrievals. Tell us a little bit about yourself and what you're doing.
It is. Well, thanks, Aebhric, and thanks for having me on the podcast. So, that's right. I am a special operations medic in the United States military, and I'm out here at Hawaii, and I work for the Defense POW MIA Accounting Agency, and we have a humanitarian role. And we go to all the austere locations for remains recoveries from our charters from World War II on. So that can go all the way from the Pacific, which is my main focus, being out here in Hawaii, but we have teams that go all over Europe and about anywhere you can try to imagine in the world where we fought and try to recover remains.
So what countries have you been to so far?
So I've only been to two, and I'm kind of stuck in those two with my luck of the draw. But good countries nonetheless. But Laos and Malaysia is where I've been to.
What does a normal deployment look like? Describe your day-to-day on a normal deployment.
Yeah, so and I'll start. The timeline really starts before we go out the door. There's of course. Planning and investigation for the mission and exactly what we want to go do as a whole team in its entirety, and that's really done by other people. So I'll kind of stick with the medicine because I think that's where people are going to be, most interested with. And so we start with once our team roster gets built, and most of this is internal. Some of this is external, and when we build the real big teams, a lot of it's external. I mean, we can go with 100 augmentees from different units around the military, and
Wow.
and so medically we start to cover quite a bit. And part of those augmentees will be we call independent providers. So they'll be SOCMs or special operations medics or 18 Deltas. But most commonly, they'll be Air Force independent duty medical technicians or Navy independent duty corpsmen. And they'll kind of help us as the organic medic, as we call it, and they'll kind of cover down on a team. But we go through everyone, and we do very robust health checks on everybody. Where we go, the healthcare systems are usually not going to match up to where we came from.
No doubt.
And then the evac times can be extreme. I mean, they can be 24 to 48 hours to get them to a hospital in that region that really meets the standards we need it to for what they need. And so we do a pretty big deep dive on that and just trying to make sure that there's something in their past history that's not a red flag to us. And it can be something as simple as we see somebody has a hernia that's not been operated on. It's okay. Well, we probably don't want that out there, digging and possibly exacerbating that. And so that's a big deep dive that we do, and can take quite a bit of time depending how big the teams are. We do smaller teams, our investigation teams, and they're 10 people, but they'll usually go out with a couple recovery teams, which can be 30, 40 people a team. And when you add, I think back in the day prior to COVID, we had 4 or 5 of those teams go out at once, so that the missions can get quite large. And then what we do on our side is we will then pack out. We pack out everything. We diligently go through all the kits. We do our pre-mission checks and inspections and make sure that everything that we do have is good to go for the augmentees that are coming in, and that seems kind of a place where people gloss over. Of packing out seems the more boring piece, but the quality of medicine that can be done in an emergency a lot of times falls back on how organized you have something packed and laid out and systematic and things like that. And so I spend a good deal of my time to make sure that it makes sense. It's clearly labeled. It's where it should be. It doesn't move. It survives the flight over there on military transport or civilian air. And that way, from as soon as we get there, it's really set up your station as it should be expeditious, so it should only take a few minutes to set up, and good to start receiving patients in case worse comes to worse. So that's really the pre-mission. We get our augmentees, we kind of bring them into the fold, and talk to them about our policies and how we run, because it's going to be different from how they run in their unit. And then we push out, and my goal on these missions, I tell everybody, is to not be a medic. That's really what I tell everyone. I don't want to do anything medical. Because again, the environment to do medical things is not the greatest.
So you have up to 100 soldiers deployed, and you're the only medics. That's almost 3 companies worth of soldiers, and you're the only medic?
So they're for the teams, for about those RT teams of about every 30. We will have an augmentee medic that's with them, an IDMT. But overall, if something happens within theater, if you're the organic medic, you're responsible. You're probably going to move and respond and take care of the situation as it happens. They're going to have to start dealing with what's on hand first if it's one of theirs, but they need to be contacting you. And then, if it's anything serious, you got to start shifting forces and trying to get over to them, and then start coordinating for evacuation and, letting everyone know what's going on.
So you are working out of an improvised clinic. Are you palletizing medical equipment, or is it vehicle mounted? Is this a rucksack mounted, or what are you working out of?
Yeah, good question. It can be all the above. It really depends on your mission. All these places are different places. They all have different aspects to that mission, and sometimes with the mission, that last mission, it changed multiple times within there, where I was doing rucksack medicine. At one point, I had a small rotary wing aircraft that was could hold about 4 people, and I could keep a little bit more kit in there. I set up a clinic in my hotel room if I have one. If we're in tents, I usually have a space set up outside. Try to get an overhang or something built with a tarp and set up a clinic out there. Really, it's just. It really depends. If you're on a recovery team, typically it's a bit more traditional, and you set up an aid station, if you will, out where your recovery team's at. But everything gets there through usually palletization in for military aircraft. But like this trip to Malaysia, everything had to go civilian air, and so I had to pack in a way that met requirements for weight, and had to do all my notifications to make sure things passed through countries, and I'd have it on the other side. And so it's part of that planning process goes into that, and seeing what your mission will look like on the ground when you're physically there.
That's a tough one for pre-deployment planning, then, isn't it? Because if you're flying commercial, what do you had 3 foot lockers you're allowed to bring? And at 50 pounds a piece, that's not a lot of equipment if you're setting up a clinic.
No, it's really not. It can be it can be changed. We can bring in more equipment. The DPAA is which that's the acronym of where we work for, is they're willing to make sure that we can, buy excess baggage fees and things like that, and make sure that we can get out there. But you do have to be smart in how things pack and break down. And traditionally we would lug around these big Pelican cases. Well, that doesn't really work in this environment because you're not going to be able to fill it all the way, and you're not going to be able to really utilize that as you would with the weight that the case has in itself. So we have to, be smart in how we do things and pack things, and try to find a modular system over a fixed, rigid kind of system that should work for everything.
And on top of that, you're bringing drugs. So Malaysia is an Islamic country. How were you able to bring in your ketamine and morphine into a country that makes that illegal?
Yeah. So we use diplomatic notes, and I reached out to, we send up everything saying this is what we're bringing because this is what we need, and that does go to, I'm not exactly sure who that goes to in Malaysia. Probably the Ministry of Defense there, and a few other people, but. Also on the same side, I would speak to our embassy and, hey, this is what I'm doing. I'm sure your team's tracking I'm there. I don't know if you're tracking, though, that I bring in quite a robust kit, narcotics being the most worrisome. Second, my fear of having a serious casualty in a, country that's developing. Second to that would probably be in jail in a country that's developing. And so I want to avoid jail time or anything like that, especially when you're not meaning to do anything, nefarious. You're just trying to look out for your guys. But even all the, controlled substances that aren't necessarily narcotics, but antibiotics and things like that, a lot of that's not allowed in these countries unless you're a physician bringing it over on prescription. And so even all that, and so I'll take my entire list. I'll take my lot numbers, my expiration dates, my quantities. I will let them know the whole gambit. I don't try to hide anything. And then I send that up early enough where it gives them comfortable time to be able to say no or yes to things. Usually, if we are diligent and respectful, most countries don't have an issue. I think there's only one country that kind of has an issue with us bringing stuff in and out, and that's a developing relationship, and that will have to be fixed outside of the medical realm. That will have to just be through talks with leadership at that point.
So you're going into let's say Malaysia, the last one you went into. How did you set up your PACE plan for treatment? Did you recce local hospitals as part of your PACE plan to bring casualties in, or were you looking to extract immediately into someplace out of the country?
Yeah, great question. So Malaysia being, one of the more developed countries we go to, it changed, and I guess I can talk about between that and Laos about how I view my medical planning there. So Malaysia has some pretty decent hospitals there. So I did a significant amount of research on those hospitals, and we worked through a few organizations too, and so we take their recommendations, and so I look at the recommendations of International SOS and a few other organizations and see if have they been to those hospitals to do a survey, what that looks like, what the capabilities look like. And so the path we took is we did a tour around the peninsula. I mean, we did a full 360 around it. And so it really became a moving target for me. And I had to find the ones that were close enough to where we were staying, and what hospitals to go to, what not to go to. And sometimes this is easy. Actually, in the capital, there's a hospital that is actually takes our military health insurance. It's like, well, that's going to be an easy one there. That's probably been vetted multiple times for that to happen. But some of these outliers, it gets a bit more difficult. And so we use those organizations, And we look at the hospital. You have to look at how you get to the hospital, and then how you get out of the hospital, because all those are new phases within treatment that you're going to have to take care of. So while the private hospitals in Malaysia are very good, there's you know good cases that come out of them. Many of the physicians are Western trained or had Western residencies. They're well stocked. They're clean. A few of them were actually JACO, Joint Commission
Yeah. Wow.
approved, and it was like, okay, well, this is really nice. Where Malaysia had more difficulty is the pre-hospital care is nothing like on the west side. It's still very much in its, I don't even know if infancy is really the best place to say. It's probably akin to 1960s United States pre-hospital care at that point, kind of a
Before
scoop and go.
paramedics. Yeah.
Yep. And so that really became a focus of treatment that I needed to make sure that we were good for. And I needed to look at, make sure all the hospitals, could they receive a patient 24/7, and what staff was there. And then with my transport times, as we're moving, look at what my long legs of the transport were to make sure that I was prepared for my longest movements. And I always double that just out of caution. I double it because things can go wrong, and I just want to make sure that I have enough. You think you're transporting, and then you have car trouble or something of the sort,
Murphy.
and then
Yeah.
it makes everything a bit longer. And then I also look for the post care out of the hospital. How do we get them from hospital to international airport to try to get them on a flight back? And back, maybe all they made it to was Korea, or
Right.
Japan or something like that.
Yeah.
Yeah, exactly. One of those were robust medical system that could handle whatever we bring them as a patient. But so we start to look at all that, and part of that, looking into that, is what is the reality of the diplomatic process of somebody leaving from an airfield that's usually not their main port of entry or exit, and what that's going to be. And honestly, that's where like the embassy has to start getting into it also, and kind of aiding you in some of those things, and some of the evacuation companies can help with that too. Depending on your country, it can be kind of how difficult that is. Now, Laos is quite a bit different. Laos, the only hospitals that really feel comfortable with is in the capital city of Vientiane. And so for you to evac somebody, this last trip, I was all the way down in the south of it, and I was not going to be allowed to cross any borders. So we were going to have to work our way all the way up, the length of the country, probably by driving. I had a helicopter, but it couldn't fly at night. And so, around when dusk happened, that was it. A good run with that helicopter would probably be a 4-hour flight. And so I told the guys, once about 3:00 rolled down, we're going to be driving somewhere, to be safer while we're on the work site at that point, essentially. And so for them, there was also the facilities we just aren't quite as robust as we need. And what we can do is we'll go do site surveys to hospitals and try to develop our own reporting too internally. And we'll take what we can use from these hospitals, and it may be laboratory capabilities, x-ray capabilities, leverage what we can use that will at least give us better decision making before we start a evacuation. The evacuations, I know it's military, but everything has a price tag on it. And it's the amount of money you can save off of good clinical decision making is pretty big and appreciated once you do that appropriately.
Indeed. And have the ability to make clinical judgments on, do they need to exfil or not. So
Yep.
An ultrasound probe would be. What do you carry one in country to help you make this decision?
I do. I wasn't able to take one in Malaysia with me, but in my kit, I do. I carry a ultrasound probe, and we anything we can look at with ultrasound is excellent, even if you have to send pictures to people because you're not sure what you're looking at. It's much easier to uh, use the local cellular network or internet and send a picture than it is to try to figure out what something is with less diagnostic capability for sure.
Hmm. It's always good to phone a friend.
Yeah, 100%. I think the providers sometimes get tired of me because I'll fill them in on even the more basic things we have to make sure I'm not being silly with my medicine and that I'm not missing something important.
So, what medical ailments, what injuries are you seeing on these deployments?
Most of them are what you would expect. The most common ones we deal with are traveler's diarrhea, or it may be a little bit more of, a enteritis, sometimes something more dysenteric will occur. Lots of musculoskeletal stuff. The work sites on these, they're more akin to a construction site than they are anything else.
Hmm.
Lots of digging, lots of moving materials, and people get worn out. Especially if you're not used to doing that, your body has an adjustment period, and so that's pretty common. You deal with the more common ailments that we have here, headaches. People get the upper respiratory infections and things like that. And so really, the mundane, is kind of what you see, the things that you are prepared to. And then every now and then we get things that are a bit more exciting. Sometimes we do get injuries. We had one of our guys was in Papua New Guinea and had a interesting meningitis case.
Hmm.
Um, and so you can go from these, it's not deadly, to it's potentially very life threatening very quickly. And sometimes they mask each other. A simple headache with a bad examination, it just becomes a simple headache. And then with a good one, you start worrying about encephalitis or meningitis or something that's kind of presenting a little bit extra because you went the extra mile to do a good examination. The I would say the most interesting cases I had were I had a bubonic plague case with
Wow.
a local national in Laos. Um, that was the most interesting I had there. Everything was other than that was really focused on GI. I had a big GI trip that time.
Hmm.
Um, and then in Malaysia here, I had an interesting anticholinergic toxicity where I was my own patient. And then I had a urology patient with interesting presentation of kidney stones, and
Hmm.
all those make you use your medical brain to the max. And those they're fun when it's over. You look back and it's like, well, that was good. But when you're in the moment, there's quite a few worries and um, you know I don't know if self-doubt's the word, but there's doubt going on in your mind trying to figure out what you have, especially if your telemedicine capabilities aren't quite the best.
Indeed. Well, I would be remiss if I didn't ask about malaria, dengue, other tropical diseases. Are these popping up as well?
We do, and I should have said that. I guess at this point, when I say common things, tropical medicine has become common to us. It's just part of the lifestyle at this point. Now, we do a pretty good job with prophylactic treatment. The teams go out either on, and forgive me because I can never say the generic name of this, but Malarone is
Hmm.
what I prefer to put my team on, and or the possibility of people being on doxycycline. One of those two, and so we do a lot of prep, a lot of preventative medicine with that stuff. We make sure that everyone can take the meds, and then, of course, on the way back, to make sure that everyone can take Primaquine as long as their G6PD levels are appropriate. You
Mm-hmm.
know, so
Okay.
we have good compliance with that, and I think that's a military thing in general. We've been taking uh, anti-malarials for 20 years at this point, and people really have it in their mind that you need to do it. And if you're military, there's repercussions if you didn't take it appropriately. So that's there for malaria. But I'll say those cases because of that are rather rare. And we
Mm.
use lots of bug spray. If I can, I'll even ship in these fogger sprays for the sites and try to, first light when we're out there, try to fog the area and at least, keep the pest out as much as possible. And with dengue, being in Malaysia here, Malaysia is actually having a dengue outbreak, which when we showed up was about 3,200 cases a week in
Wow.
the capital city of Kuala Lumpur. And they seem to be doing an amazing job as a country managing that. Their fatality rate is extremely low, and so they know what they're doing out there. Um, but I was, still worried about my team because we spent about 5 days total there. And so we did the permethrin treatment close. We, put bug spray on before we went out. If we felt there were mosquitoes around, perhaps we're eating and there's mosquitoes around, we just kind of cleared out. And luckily, we didn't have any cases of dengue while we were there.
Mm.
But it's something that you have to worry about. And in our history,
Indeed.
we've definitely had people get dengue. I'm not tracking any who've become, the critical stage 2, but um, nothing too serious. But I know the one of my good friends, an archaeologist for us, who had it. He said he never wants it again. He said that was the worst thing that he experienced while his time has been here for sure.
And are you carrying RDTs for all of this as well?
We do. We try to carry the RDTs are for dengue are hard to get right now because
Mm.
of the outbreaks that are happening within Southeast Asia. If you're a U.S. Based entity, you have to get special approval to get those or go buy them in country if they sell them available. But I
Mm.
try to bring every RDT I can, every lab diagnostic capability I can. I'll bring. We use the Bionax is the FDA approved for malaria. I had to go to the embassy to get some dengue rapid tests. We'll use influenza, COVID. If it exists while we're out there, we will try to bring it with us because that makes
Mm.
clinical decision making much easier. When you have positive malaria, well, you definitely know it's malaria at that point.
Are you bringing microscopes and slide staining as well?
No, that's where we start to taper off at. And truthfully, we have we have one special forces medic that's with us now, and he would be the most trained to be able to do that. And I've done it, in the master's program, and I've done it through the Walter Reed Tropical Medicine and Global Health course, and
Nice.
so I got to do quite a bit of reading there. But the amount of material that we would bring for that would be quite extensive, and so we choose that it's more prudent to bring more rapid tests than it is to bring a microscope and slides and stains and all those sort of things.
I agree. And they are 95% correct on the RDTs. So you're not
Mhm.
wrong on that. The other test I would think of would be a guaiac test for blood in the stool to determine dysentery. Do you have that option as well?
We do. Yep. Guaiac
Yeah.
tests are available for us, and I will bring those for sure. I always trust the guys when they say that they don't see any blood in there. I believe they don't see any blood in there. But for those persistent or particularly bad diarrheas, or if they're presenting with a fever or anything like that, sure enough, I'll get a guaiac test on them.
So musculoskeletal, like sprains, strains, back problems, a little bit of trop med. Anything else of interest you're seeing?
I think that's probably the majority of what we see. If we start to see anything else, it's more kind of rare, and a lot of times it happens to do with chronic problems that they have. I've managed gout out there. Um,
Oh,
kind of one-offs that are out there, but you will see them,
hmm,
um, and it will really start to test your medical skills there. As a paramedic, you're not necessarily trained in to be recognizing and treating gout. And as a military medic, usually our patient population, a lot of them don't have gout. I
hmm,
will say the one thing that we're definitely prepared for is all the cardiac events, the hypo or hyperglycemia, anything like that. We take a full complement. I'll bring all the ACLS drugs I can
good.
possibly bring, and I think you actually have a picture of my kit. And on my kit, if you look on the back lid of it when it's open, you'll see it clearly labeled with all my cardiac meds on the back there, and we'll bring AED at a minimum. If you're a bigger team, you'll bring a monitor, to be able to do a little bit more in-depth study on this. And sometimes it's we're a bit more cautious because the age of some people we bring with us. That's happened quite a few times where we bring they're fantastic trips in my opinion, but you bring people who were in the battle out with you, and and they can be U.S. or they can be from another country, and they can help you with your investigation skills. But at this point, with the age of them, there's expected to be quite a few, you know, medical problems with them at that point, and so I'm especially cautious with those that we bring, and making sure that I'm doing the best I can to provide them health care for what they have too at the same time.
Yeah, old man disease is getting a lot of us now, so it's probably a good idea
it
to
it happens,
focus that. Yeah. So, what's the longest case you had for prolonged field care that you sat on a person before you got complete medevac?
I've not had to do a complete full medevac for anyone out here. We've been pretty lucky for me personally. For some of the other guys though, the meningitis patient we had, it was a full 48 hours for them to be able to go, and that I was on the receiving of telemed for that, trying to work them through and coach them through on certain things there, at least the critical care aspects of it,
Mm.
trying to make sure we had good communication, while another side of it was trying to work on the getting them out of country process, which sometimes is the more difficult process. But I will say I had this urology patient, this kidney stone patient that I had. He wasn't a urgent evac or anything like that, but he did. I did have him for 5 days of rather questionable things, where in the U.S. he would have gone to the emergency room and to a urologist, quickly, and
Mm.
so it's it's not the big evac that we all expect of somebody found a mine out there, or somebody has you know dengue hemorrhagic fever or something like that, but it's still a prolonged field care question that you sit on, that typically you would have handed this patient over quickly, just going to the emergency room, and that would have been the scope of your care is really just doing an assessment, treating some pain, and getting them to the emergency room. Where now I had to maintain a patient with kidney stones who were bordering a complicated versus uncomplicated, and trying to avoid them going to surgery at least until we got to the United States.
That is a challenge. And how much pain management drugs do you have available for sitting on a patient for 48 hours?
We have quite a bit. We do our calculations to make sure that we can handle what we do, what we are going to face. And so we carry a couple grams of ketamine, and a couple is, really at least 3 grams of ketamine are with us. And we have, you know, opioids, we have benzos with us. And then we also have kind of the, Percocets. We start working to our lesser drugs, carrying ketorolac and all types of other NSAIDs and things like that. So we can augment pain pretty well for 48 hours. That's one thing I kind of refuse to work in, is keeping somebody in pain for 48 hours. That would be a nightmare. So I make sure that my narcotics are pretty robust.
Indeed. That sounds pretty amazing, what you do for a day-to-day job. And it's a 3-year stint, is it?
It is. It's a 3-year, and if you really want to, you can always extend for a fourth. We just had one of our Air Force medics do that. He's a great medic, fantastic clinician, and we decided that we will, have him do another year out here. And it is a great duty assignment. There's dive missions that happen, so we have some people to go do dive medicine. We have a lot of technical, I'll call it technical recovery. I don't think if that's really probably used appropriately, but a lot of these sites, we have cliffs or it's on a 60-degree slope or something of the sort, and we're working on ropes while we're excavating. And so the medics are very well trained. Multiple courses that guys go to. We use the military mountain course out in Vermont, and we do go over to Bridgeport with the Marines, and we do stuff on island through a local company, and we train that quite a bit. Actually, that's you want to talk about delay to care. Don't have a good understanding of ropes when you're on a ropes mission, and you may delay care quite a bit. So we actually train twice a month as a team. We make sure that if you're here, you're going to train in your basic rope skills.
Yeah, definitely need to have those and make sure that everyone's tied in. So, Zack, you who are currently going through our Masters of Austere Critical Care, and we met in Pretty Bay, Malta last winter.
Yeah.
Tell us about the program and why did you take it and what are you learning?
Yeah, so I had been looking for a program for quite a while. And when I say quite a while, I mean I was probably looking at programs for 4 to 5 years. And I was very disappointed in the US for any postgraduate degrees. And honestly, kind of even undergraduate degrees, I was disappointed in. There's the point where for a paramedic, which is what I was kind of basing my programs off of, is you do kind of the basic paramedic program, and my hope is to be able to find a program that weeds out the stuff I don't care about. Give me the basic education I need in math and in English and those things, but focus me in medicine. That's what I want. I want to do medicine. I don't want to do all these other courses. I don't want to spend my money on them. I know I won't do as well in them because I don't care about them. I probably should, but I don't. And so I'd looked for a long time, and in the U.S. for postgraduate, there's nothing that does that for paramedics. The U.S., they very much segregate degrees by what your career field is. Physicians do their postgraduate critical care course, and perhaps mid-levels will be in there with them, or mid-levels have their own. In mid-levels by PAs and nurse practitioners. I know they don't like the term of mid-level. I apologize if that offends anyone there. And then nurses will have their own. In paramedics, there's really nothing that specializes you. And if you look at most of the degrees in the U.S., a lot of it's management. And I've had plenty of management in my service career, and I don't feel like doing more management courses. Nor is that kind of what I want to do when I get out. And so when I came across your course, and I noticed the European model is quite different. I mean, you go to a course that they'll let you sign up for it as long as you have the undergrad to get into it. They don't care, and it's open to specialties, across the spectrum. And
Mm.
I ran across yours, and or the college's program, and really what got me about it is there's no extra courses in there. I mean, there's nothing. There's no there's no introduction course where you pay for an extra semester hour of something non-medical to introduce yourself to everyone. Um,
Mm.
and so every course was a valuable course. And that was really one of the first programs I came across. And then it had this austere flavor to it. And it's such a undeveloped aspect within the US of, austere medical care. Uh, it almost just doesn't exist out here. The best thing you can do is take a tropical medicine course, and they'll talk a little bit
Mm.
about it. There's a few degrees where they've started to do like disaster medicine, but again, those are all really for physicians as fellowships, not
Yeah.
for medics to jump in on. And so I saw this with the college, and immediately I knew like that this is it. This is where this is where I need to do school at. You know, at that point, I think I'd emailed you and we talked, and you guys, you cared about you cared about me learning, if that makes sense.
Mm.
Like you were interested in me as a student picking up skills and abilities, and you could tell that you weren't just trying to make a dime off of students. Some of these colleges feel like a puppy mill where you go in, you give them an arm and a leg, and then in 3 years later, you'll walk out with a degree. And I never got that sense from you guys at all, and I appreciated that. And I believe when we had that conversation, Paul was actually in the room overhearing it, and he's like, "I want to do it too." And so he was convinced on the spot also of like, yeah, this is I want to do that also. It sounds phenomenal.
So you're halfway through now.
Yeah, well, I think I'm a little bit over halfway through. I'm in 705 right now, and the last bit after here is I have I got to remember. I think it's 709, which is for the dissertation. The
Yep. The research methods.
yep, research methods,
Yep.
and then followed on by the dissertation. And so I'm seeing the light at the end of the tunnel. We're at the end there, but it's been yeah, it's been a great journey throughout this course. It's really been appreciated to go through, and the knowledge that I've gained has been appreciated by my peers and by other healthcare professionals. And actually, my PA, as we talk, PAs in the U.S. are trained on family medicine. If you go through a course, it's family medicine focused. It doesn't matter. You get your master's as in your PANSI exam of what they call it here. It's all focused on family medicine. And so
Mm.
he started to admit when I was calling him about my urology patient and just updating him, he said, "Look, Zach, whatever you think is appropriate here, you do." He's like, "At this point with your education," he's like, "I look at you more as a peer than I do as I'm, over you, and I'm going to tell you." So he's like, "You tell me what you're feeling, and you're probably right in it." And I can accredit that to being with the college for these past couple of years, going through
Wow.
courses for sure.
That is fantastic. And that's our goal as well, to
Yeah,
get
yeah,
you thinking at the master's level. So you also came to Pretty Bay in Malta, and we were showing the improvised womb vac. And I remember you came up with a novel way of detecting the negative pressure in our improvised wound vac.
yeah. That was, and this is what I love about austere medicine is sometimes you get to MacGyver it. And if you have a medical mind that also enjoys a little bit of problem solving, you get to problem solve in unique ways. And so, yeah, we were sitting there. I know we had to talk about wounds, and it was fairly in depth because a lot of the class, if you're civilian based EMS, wounds are a very short term problem for you. You kind of care, is it
Mm.
bleeding or not? And then after that, you're kind of good with it. Um, so we went into depth with this, and we talked about all the debridements. We talked about keeping it clean and closure of the wound, like what methods work best for the environment we're in. And we talked about like the wound vac there. And, quickly in an austere course, when you talk about equipment, questions get raised, of like, well, am I going to have a, wound vac kit with me? Is that going to be likely? And so, you're like, no, but here's some things we're looking at. And so I had a good, I took extra time on the side. I think we were dealing with something more I was familiar with, and so you kind of let me go off on the side and develop try to develop how I could monitor what pressure we're putting into the wound, and so using a blood pressure, not the cuff, but the bulb itself, some tubing, and creating a loop with fluid in it, and able to look at changes of positive pressure and negative pressure should have been the same, and so able to somewhat accurately, I'm not going to say perfectly accurately, but to be able to predict what pressure or negative pressure you were putting on a wound. And that was a fun exercise for me to do. I really enjoyed that one.
That is a fascination of austere medicine, isn't it? That you have to think outside the box.
Absolutely. It's a problem within a problem set is how I tell people. That's the best way I can describe it, of especially to physicians who know what to do. We've taken critical care physicians, infectious disease physicians, and I'm preparing. They'll say, "Well, what should I be ready for?" Well, you're going to have a problem, but you as a physician, you're probably going to know what to do. If you were here in the United States, the problem is you're not in the United States, so you have this problem within the problem, and the problem may be diagnostic limitations, or equipment limitations, or medication limitations. But now you have this problem within the problem, so you get to problem solve. And yeah, it's if anything, it's my favorite piece within austere medicine.
And it's interesting teaching this because I hope I'm learning more. I think I am. I am learning more from the students who are going through the austere critical care classroom session in Pretty Bay, and just seeing how they come up with solutions to the problems we're throwing them. And I mean, there's 16 scenarios during that week, and you guys have to come up with ways to deal with these casualties and austere, critical casualties in austere environments. And it's a learning experience I've been doing this 35 years and I'm still learning. And I think the day I stop learning, I'll quit. But your class was really interesting just to see how you approached each of these 16 scenarios.
Yeah, the scenarios are they're wonderful scenarios. I've been you know, as a special operations medic, we've tried to create prolonged field care scenarios, and the start of that, the genesis of I think more of the big mainline push, prolongedfieldcare.org and things like that, came out of my community. But the ones that the college does are spot on to get you thinking too. They're good scenarios without easy solutions to them, and they were fun to work through. They were very, very different, and even the ones where you're like, oh, okay, I've seen something like this. There's always a twist in austere medicine. There just always is, and your scenarios always brought in a twist where you're like, okay, I didn't see that coming in here. So what do we got to do here? So especially if you're not familiar with the austere environment, if you just don't have a ton of practice, those scenarios are phenomenal. I would say invaluable to get your mind starting to think of how this is going to look and present itself, and what your mind needs to be ready to do and start changing of preparedness and what you're thinking, and possibilities of what can occur. And so I really enjoyed those. You guys did a very good job getting those set up and presented to us, and throwing us those curveballs in there for sure.
It was a group effort of having, well, Dr. Chubba is our chair of critical care, and he kind of reviews these and makes sure that we're not going off on deep end and throwing you wazoo things, but it's you have to basically having 17 good faculty members that are making this happen. So, Zach, what advice? My last question for you, mate, is what advice would you have for someone starting out on a career in austere medicine?
Oh, good, yeah, good question there. I think a few things. I think the most basic thing I would say is your basics have to be spot on. I mean, they've got to be good. There's no progressing past the bad fundamentals of medicine, because you will chase your tail the entire time. So be good at whatever your level is. Those fundamentals need to be down pat, and I recommend doing your pre-research of where you want to go or what you want to do, and double check that you're not missing any of those fundamentals within there. So fundamentals have to be down pat. And then two, I would say that if you're trying to come into this community, you need to start looking at the areas you're uncomfortable with, and becoming comfortable with them. So after those basics of basic wound management, basic bleeding control, things like that, now you're going to move into a longer term, and that's not commonly done within our segmented healthcare system. A nurse has their portion, a provider has their portion, pre-hospital has their portion, lab has theirs. Well, now you expand significantly to all roles are done by one role. Even if you have telemedicine there, nobody's there to give the IV but you. And so if you're a physician and you don't give IVs, those things have to be done, particularly well. If you're not used to diagnosing and creating a differential or anything like that, those are now on you, and so you need to be prepared to deal with that side of medicine, which you may not have dealt with before. And then lastly, I'll just say, the education of it is there's no way you will know everything that you need to do. You are going to constantly be focused with problem or faced with problems that are going to be from one specialty, and then you'll get another problem, and that would be a whole nother specialty who would deal with that. And so the learning that you do just needs to be constant. And I think that's what I appreciate about the college is they lay a great foundation for that. But you have to constantly be digesting information and trying to figure out how to shore up your deficiencies that you have within medicine and learning, and whether it's reading articles or sometimes it's simple as watching YouTube videos, and seeing how somebody, it could be, a more simple thing is how do you cut an EpiPen to get the rest of the doses out of there. But that constant set of learning, and those who constantly learn are on a new wavelength. They just are quickly, they outpace their peers, and they're much more ready. Even if they didn't particularly train for one area, just the cross knowledge. They always do better. And I had a senior medic who was with me on a resuscitation team, and he did this. He read a journal article a night, and he was a phenomenal medic, probably the best special operations medic that I had worked with in my career. And so I learned that from him immediately, and tried to discipline myself to be able to do that. I still probably don't meet his standards with it, but I think if you want to do that, that's probably where I would start with.
Know the basics well.
Yeah, the basics well. If one thing, you got to know those basics well, for sure.
Zack, it's been fantastic chatting with you for an hour, and I have been looking forward to this for quite a bit. And thank you for taking the time, and thank you for being part of the college.
Yeah, absolutely. Happy to do the podcast, and happy to share my knowledge. I know I have a kind of an interesting background with this, and we're happy to talk about what we do. And it's been a pleasure to be part of the school too. I appreciate everything and all the professors there. It's been a wonderful experience, and I appreciate that.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.